I'm going to focus more on sort of the biology of ARA and DHA, leaning a little bit more of the preclinical data, as we saw already a nice illustration of the clinical data. And collectively, sort of how do we bring this information together to help guide future nutritional strategies? As mentioned, because our babies and preterm babies are not fed immediately, despite knowing that we don't maybe have an optimal lipid emulsion and there are risks of intravenous lipid emulsions, we are stuck in having to provide some early lipid to make sure we're delivering appropriate fat delivery for the provision of essential fatty acids to maintain a positive energy balance for growth. And it's also an important substrate with protein and glucose to maintain euglycemia. But sort of as mentioned, the fatty acid composition of the lipid emulsions will be important as well as in the overall diet, because it's really the unsaturated versus saturated and the relative composition or dose of DHA and ARA that are very important in maintaining the structure of our cells, the fluidity and function of them, how it's going to signal to the nucleus, and really regulating proteins and molecules that are important for immune and inflammatory responses, but very specifically to the neonatal population, also organogenesis as it is not complete, homeostasis, and repair. You've seen this graph of sort of the fatty acid metabolic pathways. I just have highlighted that also considerations to their terminal mediators and why they do have such an impact on biology. And for DHA, it's the resolvins and neuroprotections. And for arachidonic acid, it's the prostaglandins, lipoxins, the epoxy-eicosanoids, all of those, not in the inflammatory pathway necessarily, but in the organogenic and repair pathway. That is very important. So when I kind of think about where I want to be in fatty acid balance, and especially again in preterm infants, I think about two main things. One is what was supposed to happen in utero? And second, what are the postnatal transitions that we see? So in utero, a long-standing science that has held sort of the test of time, we're on the left panel, this understanding of biomagnification and a selectivity largely for DHA and ARA, again, speaking to the impact those fatty acids have on fetal development. And you see that as the pregnancy goes on, and especially in that third trimester, on the left panel, the dotted line for the fetus, that their DHA composition and fatty acid and phospholipids outpaces that's in the maternal circulation, and hence the name biomagnification. In the middle, we see that when you compare the plasma compartments, much higher DHA and ARA relative to the mom's circulation. But also, I think if you focus in on the fetal compartment, you begin to see the relative balance of ARA to DHA. And collectively, whether you're looking in the plasma or the brain or the adipose, ARA is at 2, 3, sometimes even up to 9 times higher than what we see in DHA. So there is this omega-6 dominance during early fetal development, and I'll argue for our preterm infants as well in the NICU. On the right is just a reminder that fat in adipose tissue sort of serves as our reservoirs of these important lipid molecules, but when born at 25 weeks, even 30 weeks and less, 32 weeks and less, the amount of orange there, the amount of fat in adipose tissue is really small, and thus infants are immediately reliant, preterm infants are immediately reliant on our nutritional strategies in maintaining some fatty acid balance. And what we do see, and it's been repeated in multiple studies, you saw it in the data Dr. Carnielli mentioned, and Dr. Leaf, I think, was one of the original ones, and we repeated this data, where fatty acid levels do rapidly change after delivery. And so I sort of have it in 3 phases, where the first phase during early period, within a week, you see this drop in DHA, you see a similar drop in arachidonic acid, you see an excess, almost 3-fold in LA. So these values and the relative balance to each other are completely reversed to what they were seeing in utero. And these deficits and excesses maintain itself during the prolonged NICU stay, the period at which preterm infants are ongoing their development, developing their immune system, regulating important inflammation in the NICU environment. And then these changes have been linked to outcomes, where low DHA has been linked to bronchopulmonary dysplasia, low arachidonic acid to nosocomial sepsis, low arachidonic acid to retinopathy of prematurity, and so on. So it matters, and we do have to try to figure out what to do for these infants to make these outcomes better. I want to talk about the balance as well as the impact of ARA and DHA in three key domains: organogenesis, innate immunity, and inflammation. So let's start with organogenesis and kind of the review of the data and sort of my experience in this. I've really come to think of arachidonic acid because it's so prominent early on that it really is the dominant fatty acid that's laying down the foundation. So like thinking of it like a house. It's laying down the foundation, the structure. It's beginning to sort of build what we need. And then I think DHA sort of comes in and does that finishing touches. It then sort of adds that function to that structure and optimizes that structure. But if you don't have that structure and foundation there to begin with, DHA is not going to do a whole lot. And I'll show you some data that illustrates that, and that principle that I think DHA is only as good as your ARA. So let's begin with the brain and fatty acids in the development of the brain. On the left, one of my favorite older studies, which gives us that hint where arachidonic acid is the dominant fatty acid up until like early term. And here you see that red solid line at about 37 weeks. It's really not till after that that DHA starts to take over and have a little bit more dominant presence. But during that time, up to that red line, is that rapid change in cortical development, where you're going from a very smooth brain to a much more complicated, convoluted structure. And it's that sort of, with that evolution in the structure, on the left, you're building those synaptic connections and the structures of the synapses. But then DHA definitely plays a role here, and it plays a role in refining the ability of that synaptic signaling and sort of how it performs. DHA does that in two major pathways. Neuroprotectin D1 is one pathway, and brain-derived neurotrophic factor, or BDNF, in another pathway. And so in this slide, what you see is that BDNF activates the CREB and mTOR pathways. And CREB and mTOR together regulates the growth and survival of these synaptic connections, the plasticity, sort of how they organize, and also how they signal along the synaptic connections. And so the structure was built in that till early term. Then BDNF, derived from DHA, begins to take this prominent role in really finessing those synaptic connections. There's been some nice studies where, I guess I'll bring that up a little bit later, where DHA and BDNF are closely related to each other in preclinical models as well. And I think it's relevant to what we see with DHA deprivation early in the NICU course. And staying with organogenesis, I want to move and speak a little bit more to the arachidonic acid pathway and those terminal mediators I had mentioned earlier, and beginning with lipoxygenase 4. With that early observation that these fatty acid changes in those clinical studies impacted the risk of lung disease, on the left sort of introduced a hyperoxia-induced lung model in the lab and showed that both resolvin D1 and lipoxygenase 4 made a change in hyperoxia-exposed lungs, where resolvin D1 was dominantly an anti-inflammatory response with reduction in septal wall thickness. But when you added the lipoxygenase 1, you actually started to see an improvement in the overall alveologenesis, which is that bottom right, where we didn't see with just resolvin. And together, the lung almost looks indistinguishable from that in room air. But that was my first appreciation as an investigator, where lipoxin, a ARA-derived metabolite, was organogenic, and here alveologenesis. This was repeated when looking at different lipid emulsions and showing lipid emulsions with fish oil sort of diminished alveologenesis in guinea pigs. I think we just saw Dr. Carnielli's data with the concern when you're moving away from that omega-6 to more of an omega-3 dominant diet, what that might do with lung development and saturations. And then finally, a recent paper from the Hellstrom lab showed that lower arachidonic acids were associated with more severe bronchopulmonary dysplasia. So multiple preclinical and clinical data on the importance of omega-6 dominance in lung development. In the middle panel was looking at these fatty acid imbalances in relation to intestinal development and growth. On the bottom panel is sort of that omega-3 again dominant, and the above is the wild type omega-6 dominant. And two key factors here where you see a reduction in goblet cells, so reduction in some innate immunity with omega-3 dominant exposure, dietary exposure during the developmental period, as well as lower villus height. This was repeated again in a larger animal study, preterm piglets on the right, where the purple signifies that purple bar is increased villus height compared to the other groups, which all had more of an omega-3 dominant profile. And so again, repeatedly in multiple organ systems, seeing this organogenic effect with omega-6. Kind of exciting, I think, in more recent data regarding repair from other groups. One is a large study from this was from Beth Israel Deaconess Medical Center and a bunch of collaborators, but looking at another ARA-derived metabolite, epoxy eicosanoids, and coming to the conclusion that they promoted vascularization, regeneration, and wound healing across multiple organs. As well with prostaglandins on the left is a recent study. This is a murine mouse model study of necrotizing enterocolitis, showing that the introduction of prostaglandin E2 actually reduced the severity of the induced model of necrotizing enterocolitis, in doing so probably through the vasculogenesis role of prostaglandin E2. On the right was pulling that data together with recent data from Misty Good's lab in necrotizing enterocolitis, also in preclinical models, where prostaglandin 2 is an important factor in engaging immune cells, ultimately releasing IL-22. IL-22 being important in epithelial regeneration, epithelial barrier, and decreased inflammation. And again, attenuating sort of the severity, but also promoting this repair after intestinal injury. So I kind of put repair to very similar categories, organogenesis, where you have to go back and rebuild those structures. So here's just a quick slide saying, yes, they are both important. I see arachidonic acid, omega-6, again, and sort of that repair, organogenesis, structure, whereas omega-3, some of the refinement of function, and also decreasing inflammation. So let's look at innate immunity. So on the left, just a reminder, I've already mentioned one of them, and that is here in the goblet cells, and there are other factors in that model, such as tight junctions, TLR4 receptors, and other things that were altered in sort of less innate immunity when you had an omega-6 dominant diet. On the right is zebrafish, and you may wonder, why should I care about zebrafish? But zebrafish in humans are the only ones that have this conserved OXER1 receptor. So you may miss this when you look at other preclinical models, such as the mouse or the piglet or other preclinical models. And what they found here is that this 5-oxoate, a metabolite of arachidonic acid, interfaces with this OXER1 receptor, and it's critical in that rapid innate immune defense against bacterial infections. So it goes back to, again, that innate immunity. And this comes together with sort of the observations that both I and Dr. Carnielli reported on, is that when you're reducing your sort of arachidonic acid levels, you're potentially increasing the risk of sepsis and infection. We saw that same attenuation in that early innate response to LPS when we looked at the pig model as well, where you can see on the left, very nice by the colors, just how swiftly we can induce the lipidome with the exposure of different lipid emulsions. But that lipidome and what you're inducing does matter, because when you induce and provide LPS in the left, there was only one sort of group of piglets that had that early innate response, and that was those in the soybean oil group. So there is that attenuation of innate immunity with a omega-3 dominant exposure. Finally, let's go down to inflammation. This is what I was alluding to earlier, where in the NICU, we are always concerned about inflammation. And we know chronic inflammation sort of predisposes to multiple diseases that we see. It's often the central pathway to retinopathy of prematurity, bronchopulmonary dysplasia, necrotizing enterocolitis. And here on the left, clinical data demonstrating this prolonged inflammatory, you can see it over several weeks, really predicts the incidence of cerebral palsy. And on the right, just a reminder that this LPS activation leads to microglial activation and inflammation and impaired in white matter injury. These are preclinical studies showing that DHA does attenuate that microglial activation, both in sort of the reactive oxidative species as well as the inflammatory response on the right. So DHA is a powerful anti-inflammatory agent that might be important in preterm infants, but I think it's a matter of timing and when we do that. This is just a final reminder that it's a little simplistic to say DHA is the only anti-inflammatory. As I mentioned, arachidonic acid has its own pathways where it reduces inflammation. Again, lipoxygenase 4, I showed in the earlier lung model, and in this model, it shows that it is also equally and independently important in that model in reducing CXCL2, an inflammatory marker on its way to lung injury as a result of exposure to hyperoxia. So this interplay, and I think it's important to think about this interplay and not necessarily look at one only. And this interplay is I think we're starting to get a little bit more sophisticated in how we look at this. And this is a secondary data analysis from Dr. Hellstrom's group. And I thought it was fantastic because the early reports, they mentioned how lower arachidonic acid was at risk for retinopathy of prematurity, and they didn't really see a protection of DHA. But they went back and looked at this again. And what they're showing here is that, yes, lower arachidonic acid, or higher, I should say, arachidonic acid is protective in ROP, but DHA can be in context to the level of arachidonic acid. And it was only shown to be protective in retinopathy of prematurity and reducing the odds of that when arachidonic acid levels was at sufficient and higher levels. And so again, that concept, DHA is only as good as your ARA. When you have that imbalance, you get studies like this. And I think there's been multiple studies of clinical trials where the intent was to provide an omega-3 or DHA diet. You saw this slide earlier, where good intentions but unintended harm were shifting that balance during a period of important development and repair and omega-6 need. You actually may see an increased risk in the outcomes that you were hoping to decrease. And as Dr. Carnielli said, an increase in BPD and death in this model. So I think what's going on and what we have to just sort of tease out and continue to work on this is that we're all worried about organ health and development in the NICU. And we have fatty acids that we know that are important that we could use in this process. But when we use fatty acids and we don't mind that interplay, we don't pay attention to it, if you have this DHA omega-3 struggle and tug of war and you're reducing inflammation, you're going to potentially impact the omega-6 important role in organogenesis and repair. And it may be also vice versa. So we have to, I think, be a bit more sophisticated moving forward about this interplay and what we do. So what are our nutritional strategies? Well, I don't want to go over this in too detail because I think Dr. Carnielli showed it perfectly, the shifts that you see, which are almost predictive based on just the composition. But just to highlight that when you are increasing, going from left to right on these slides, on the x-axis, and increasing delivery of omega-3, you're substantially increasing EPA, and you are significantly reducing arachidonic acid and that omega-6 to omega-3 ratio. And to remember again that when we say fish oil, it's not DHA. If it was an isolated DHA, I think maybe our world might be a little bit easier, but there's a lot of EPA in the fish oil, and EPA also may have a negative consequence to ARA. So I wonder if this is partly playing a role where despite having that increased ARA in fish oil, we're seeing decreased levels. Maybe that's mediated by that highly elevated EPA. And we know not only lipid emulsions, but even through our enteral diet, it is possible in using a well-emulsified solution, we can manipulate and shift the levels of DHA and ARA. So we have some tools at our hand, but I think we need to refine those tools and really understand the context and the timing in which we're providing them. When we look at all the different shifts of fatty acids that are induced, again, a general table, just looking at general trends. And again, Dr. Carnielli went over that, but yes, desirable to have a reduced LA rise early on. So the mixed components with and without fish oil accomplishes that. I do think we need to preserve ARA. And I think you see that less of a reduction in the soybean oil and the mixed component without the fish oil. You do get a DHA increase with SMOF lipid, not significant as much as you would guess or as long or as sustained as you would hope, but the EPA substantially is increased. And I think as a collective look, you're reversing the ARA-DHA ratio when you're adding fish oil at this point in early postnatal use in a non-surgical, to use Daniel's or Dr. Robinson's term, infant. So how have I sort of started to put this together as I think about where to go in future studies and future bedside strategies? Well, if we look again at the spectrum, N6 to N3, I think clearly the premature infant, the fetus and the premature infant is an omega-6 dominant environment. It is not done growing and developing. Yes, a switch happens. I'm not sure exactly when, close to term, early infancy probably. You do start to switch and have a more desire to have sort of an omega-3 exposure. What about in the context of development and disease? Well, development again, building organ structure, that's omega-6. But then established chronic injury, of course, there's a literature out there with white matter injury as well as, penile, severe liver injury, where we've seen the benefits of shifting to omega-3. But there's a time when you're going to need to start repairing, as shown in the necrotizing enterocolitis studies, where you need to revert back to a profile that supports recovery and regeneration. And so in conclusion, I think both are obviously important, and we see that in fetal development, but we also, I think, clearly see in fetal studies, the preclinical data, the clinical data Dr. Carnielli showed is that there's still a need for a dominance arachidonic acid or omega-6 diet in our preterm developing infants. Current practices right now fail to maintain that balance. We have a more work to do. But when this failure is linked to morbidities, the shifts we see are predictable based on composition. I think the EPA in fish oil may be more sort of our more worst enemy, and then getting it wrong does matter, and it's potentially harmful. And so thank everybody who contributes in helping me understand this science, and I thank you for your attention. Thank you very much.